Hello, everyone. Welcome to the Miracle Larry podcast. I'm Jack Cush, joined by best friend Larry Kelly. Larry, how are you?
Good, Jack. How are you?
Superb. Larry, I want to introduce you to another great friend of mine, Dr. Len Calabrese from the Cleveland Clinic. Len's a professor of medicine and immunology and all things amazing. He is at the crossroads of immunology, rheumatology, infectious disease, and he's a humanist on top of all that. He's a leader in our field. He's a leader in other fields. But best of all, he's just this dynamic, great friend. And Lenny, thank you for joining us on the podcast.
Oh, man, it's my privilege.
Thank you for being here, Lynn.
So, Larry, why don't you give Lenny a 1-minute version of what he needs to know about you?
Wow.
1 minute.
Yeah. Len, I don't know how much you know of my story, but I'm a early COVID patient and a survivor, and I had it pretty severely, and hence the moniker Miracle Larry. I happened to open my eyes from the coma on Easter Sunday, and so the New York Times sort of ran with that, and that's been my alter ego ever since. And I'm thrilled that you're here because you are dealing with this new symptom called long COVID. That must be incredibly baffling and difficult to first. My first question to you is: a patient comes in, what are you looking for to even determine that they have long COVID?
Well, Larry, first of all, I'm flattered to be here. And I'm glad that you asked this question. And this could take a minute or a year, so I'll give you the minutes version. Let me back up and go up to, like I like to say, 30,000 feet. What makes this interesting and challenging and intriguing and baffling is that this is the second time in my career that I've been confronted by total unknown. And the first time was in the early 80s when, guys were developing pneumonia and Calabrese sarcoma, and we didn't know if it was animal or vegetable or mineral. And I still have a HIV clinic once a week. I've been doing it since the very beginning. And I always said that changed my life.
I was in theater. I was in theater at the time, and very big part of my community.
So, here we are 40 years later, 50 years later, 40 years later, sorry. And a new disease arrives on the planet that we all have something to do with it. We've either had it, or we know somebody's had it, or we know somebody that's died, or we know this, that, or the other thing. And there happens to be a complication from this called long COVID, which is basically, a clinical constellation of findings that range from very mild. It sounds like what we all have. We're tired, we're achy, we can't sleep, or have, the daily rhythm of life. The people that are totally incapacitated and disabled. And unless you see the whole spectrum of it, you don't appreciate that. And so what we're looking for in people is that, if you've had COVID, what has transpired since that time, particularly since the early onset of the disease. You have new symptoms, and we're now just developing classification criteria that allow us to separate those that have it and those that don't. But we're a long way from making this, a codified disease. But fatigue, something called post-exertional malaise, which rheumatologists aren't very good about talking to the things that you used to do, get up and go out for the day and go shopping or take a walk, does that lay you low for an hour or a day or a week? Is your sleep disturbed? You have breathlessness, you have tachycardia, heart palpitations. All of this is within the umbrella of long COVID. And I happened to be at a meeting with the leading scientists in the world on this, which is held at Santa Fe. This is called the Keystone Conference, and many physician scientists are well familiar with these. This is the highest science that we have in a disease. And I was listening to stuff, for the next 3 days, as a blind man on the elephant. I know my part. These guys know their part, but we're just starting to talk to each other. So that's 30,000 feet, and it's something that we need to be knowledgeable in and be able to cope with.
So, Lenny, in your strong background in infectious disease and dealing with outbreaks of disease, starting with HIV and ending most recently with SARS-CoV-2, have you seen something else that resembles this, or can you also maybe say, is long COVID the result of a public health assault, much like we saw with 9/11 or Gulf War syndrome, and those things could be mental as much as they can be immunologic and physical. So is there a template for this?
Two things. You're really getting at it right now. Number one, as you know, I have also, one of my side gigs for the past 30 years are seeing patients with chronic fatigue syndrome, or we call MECFS. And I've written a lot of papers on this, and no one ever paid attention to it because it was a marginalized topic and a marginalized disease. And if you had it, nobody wants to see you. And I've always been impressed with this. So to answer the question number one, no, patients that have this constellation of findings are not new. And this is what we call post-infectious sequelae. We've seen it from every infections at Epstein-Barr, which is ubiquitous, to other forms of parasitic and bacterial and viral infections. And when we say MECFS, those are people that have it the worst. That is disabling. In my mind, it's almost an incurable condition. I've never seen anyone totally walk away with this, even after decades. On the other hand, the milder form of this, that I think it is reversible, and fortunately for most people, it's the majority of people, and it's very similar to conditions like you have described, a swatch of people enduring great stress and environmental changes like Gulf War illness. Patients with fibromyalgia, profound similarities between fibromyalgia and long COVID. But those patients are not at the worst end of the spectrum. And, trying to know where you draw the line, how you define it, what classification criteria can separate this out. Are there biomarkers to test for this? The answer is no at the present time. This is where it's starting to get interesting. And that's where I think that rheumatologists have so much to add to this dialogue. We understand the phenotype.
So before Larry asks his question, I want you to know that Larry's wife has complained to me because she says he won't take out the garbage and he says it's long COVID. And so, Larry, is that true?
Like long COVID to me.
She forces me. Her big expression now is "It's good OT. It's good OT." I can't. I'm learning to. I can't stand that expression. It's good OT. Everything I want, honey. Will you get me a cup of coffee? Get it yourself. It's good OT. It's good OT. It's good.
There are people that are suffering from long COVID along this spectrum, and it is a true spectrum. Some people, have symptoms for a few months. Others it lasts 6, 9, 12, 24 months. Some people function at work. Some people are incapacitated, but at its more severe end, they can't take out the garbage.
Mhm.
And some can't even get up to, take care of themselves. So, we have to be very careful in our language and be respectful for what people have.
Right.
And unfortunately, it's created a lot of divisiveness between practitioners and patients and, um, patient advocacy groups who actually were the first ones to shine a light on this. This didn't come from the NIH. Hey, there's a new disease here.
Right.
It came from patients saying like, okay, I survived COVID, but I'm not the same person that I was.
Yeah.
Is it mild, medium, or severe, or debilitating? So that's where the work to be done is right now.
Well, I've read a lot. Obviously, I read a lot on anything that has to do with COVID. And for the patients in the beginning, especially when you're talking about something like fatigue, the clinicians' first response is, well, maybe it's mental. Maybe you need to see a psychiatrist, not knowing that it's related to COVID or related to.
I have something to add to that, and I want to really interject this. If anybody remembers anything I say today, uh, I don't believe that any disease is mental per se. I mean, even mental illness is a neurophysiologic disease. But when I'm very careful to say that to my patients that the brain and the immune system are a single organ. It's not mind or body. We're all one thing. And indeed, we know from rheumatologists like Jack and I, we know that patients with fibromyalgia have a higher incidence of anxiety and depressive disorders. That doesn't mean that they are weak. It doesn't mean that they're making it up. It doesn't mean that it's all in their head. It probably is a neurophysiologic cofactor that makes them develop sleep disorders, pain, fatigue, neurocognitive disorders. And I think we're just starting to unravel that. So, I don't want to talk to the people that it's all in the body, and I don't want to talk to people that it's all in your head. It's all, involved in one thing. And I guarantee you, at the end of the day, and it may be, some years from now, we're going to learn more about suffering in chronic illness than we've ever learned before. Just listening to these scientists talk about this candidly is very refreshing to me.
I talked the last episode we had about. I tell a story of when I had first come home, and I was given this Miracle Larry tag. There was like a pressure on me to live in my own head. I was like, well, if I die, what kind of miracle is that? So there was like this stress of, how it manifested itself is I was getting depressed. And so I told Jack that, I called, and this was early 2021, right? So I was calling psychologist. And everybody was so backed up. It was COVID that I'd call in January and they, I'd say, I think I have suicide ideation. And they would say, all right, we can see you in May. And, I said, what, you're not listening to me. You're not listening to me.
So Lenny,
in my case, Len, I don't, because of what I went through and because of my age, when something happens to me, and I'm very fortunate because I don't have any lung issues, which is mind-boggling. There's a huge article in the Times today, a 3-page article about taking 3D images of the lungs of COVID patients and seeing how much damage it does. So that I have physical problems, and I have I for lack of a better word, I have mental issues. I do think I have a certain amount of PTSD.
Great. You, first of all, you're a man for sharing this, and I'm really blown away that you're so reflective on this and what was going through your head after this. And I want to be, I want to just clarify one thing for people that may be listening to this. Your story is not unique, and your trauma for what you went through with your acute and critical illness, that is something that is not new. And before COVID, patients who spent time in the ICU and dangling over a ventilator or this or that or the other thing, come out of this and really require tremendous psychological support to regain their their agency and to live their lives again. And I can, if you're half as robust as you look, I think that you've done an incredible job with that. And I think we understand that to a certain degree. The long COVID part that is even scarier, and you can tell me what you think of this, are people who were healthy, were not as old as us guys, who had a relatively mild to moderate case of COVID, miss a few days of work, kind of this, and then, something hits the fan in the 30 to 60 to 90 days afterwards, and they just not only are not getting better, but they're developing new symptoms that have progressed. And this is something that was far less well appreciated
Mhm.
in medicine in general. Like, how could that be? You got over your thing. Now, you can't move, and you get up and your heart's palpitating, and you have, pain and breathlessness, and you don't have all that scarring in your lungs like these guys in the unit. So this is there's a big umbrella here when we say long COVID.
Mhm. I know and that's my point in the beginning, is that it's baffling because there's so many different angles you can look at it. In my case, just in terms of, I was called from Mount Sinai maybe 8 months after I was home, and I was called by a researcher there that wanted me to be part of this research group of long-term COVID. But when I told them who I was and what I went through, I was rejected from the study because
Yeah.
I would throw off all their data.
No, you're in a special group. People that recover
Exactly.
from critical illness, you get your medal right up front. So,
Thank
but
you.
it is no less serious. Unfortunately, that's getting less common now as the variants have become somewhat less pathogenic, as the number of people in the community are vaccinated from that severe form. But this after mild illness thing, that is still inexplicable
Yeah.
and, really complicated. And that's where the hard work is going in right now. So it's keeping me on my toes.
See,
Larry,
I have atrophy in both hands, and I have how I describe it is from the wrist down, it's like they're asleep. I've lost the fine
Very
motor
common in
sensitive.
people in that type of unit. That's the post ICU neuropathic syndromes.
See, but they can't tell me if it's neurological or it's just atrophy from the coma, from lying on my back and being proned 3 times a day or whatever.
All under the same, all under the same
It's
umbrella.
all exactly.
You
so
know,
Larry,
Gus Springs was in the unit for 3 months, and he still has a foot drop.
Yes. Well, I have a toe drop. I had a severe foot drop. The whole thing was dropped. Now my foot is okay, except the big toe is completely dropped. It's very weird.
Your brain, and you got your breathing, and you got your sense of humor.
Well,
Bless you.
that's another thing, though, Len. I'm not even allowed to complain. I mean, it's a strange thing, but what you just said. I go every day eternally grateful, but
So, Larry, you since it's 3 years since, and you have routine doctor visits and whatnot. What's come
Mhm.
up in your mind in the last year or so when you hear about this long COVID that makes you worry that maybe you're going to have, besides the things you already mentioned, that you are there other things that you worry about?
Well, you have to remember, Jack, I'm also a very social guy. So I also talk to people, and I've sort of become this receptacle for people's near death experiences and long term hospital stays and ventilations. And so I hear so much stuff. And recently, I've been hearing a lot of this long COVID that people have been telling me I had it. And, and how come you don't have this? I don't know. I don't know. I don't know. But yours is real. Yours is real. I'm not, so
So,
I find that this topic of long COVID is coming up more, and it's 3 years later, Jack. It's three
yeah.
years, and it's
So,
you
Lenny,
know,
there's data out there about long COVID being less than people who are vaccinated. There's a lot of scientific data about the true biologic and immunologic effects of long COVID patients that really substantiate the existence of the syndrome. What else can you, being at this meeting that you're at, what else is encouraging about the scientific nature of this?
Well, the four leading theories of this are based upon hard data. We just don't know how to connect the dots. Are the persistence of the virus itself, which you can 2 years later pull it out of a mucosal biopsy of the rectosigmoid area in a lot of people. Whether that's a live virus or just viral remnants is unknown. So persistent viral infection, hypothesis number one. Dysbiosis with persistent microbiome changes at 18 to 24 months, and reactivation of latent viruses, CMV, EBV. How is that? How does that weave into this? End organ involvement, bucket number three. Presence of these amyloid-like microclots that can be found in uh, peripheral blood, muscle biopsies, bits of amyloid from patients who have with long COVID, which are inexplicable, mostly along vascular tissues. Um, uh, uh, Central sensitization, glial activation, so end organ involvement. And then the fourth one is our delia, and that is persistent low-grade inflammation, not a lot, but it's low-grade inflammation and autoreactivity. With these broad tests, people after COVID churn out autoantibodies, and whether they're driving the bus or riding in the bus is unknown. But right now, I think some of these autoantibodies are biologically active. I just saw the most interesting abstract at the meeting so far, a passive transfer model taking autoantibodies that were identified in long COVID patients, giving them to mice, and then showing that these mice have increased pain sensitivity and myocardial impairment from the autoantibodies that were harvested from long COVID patients, reproducible animal model.
Mm.
Uh, why do patients get POTS after this? Probably antibodies to G-coupled protein receptors.
get what, Len?
It's called postural orthostatic tachycardia syndrome. It's one of the most feared complications of long COVID.
Mm.
People just start, when they stand up for a while, their heart starts racing. We go 200 beats a minute, and they can't function, can't get to the bathroom. And this occurs in a small percentage of people, and these people are disabled. And in a clinic that caters to these type of patients, 2-year wait.
Mm. Well, how do you even treat it, Lynn? Is there any treatment now? What are they
A
trying?
lot of symptomatic treatment for that, but now there's a number of experimental studies going on. I'm very excited about something Jack knows about FcRn inhibitors. I think this is one of the most exciting things in immunology right now. It's a little aside to the rheumatologists who might be listening to this, and very, very interested in this. A lot of talk right here at this meeting on it.
But we're still at the stages of understanding it, and that's probably the first big mountain we've got to climb, right? Really, truly understanding this, which
The
then,
immunology guys need to talk to the guys who are clinically curating these patients.
right.
Right now, it's just like, oh yeah, we have long COVID. Well, tell me about those people. Well, they have long COVID. They have persistent symptoms. Which ones? How bad is it? What's their quality of life? I want to know all this stuff. And we said, well, so now those phenotypes are being defined, and it's this is the most exciting meeting I've been to in years. So,
Len, can I ask you a question? This is all right. This is going to sound weird, right?
Uh-oh.
But it's just something I thought about like a long time ago.
And the children to bed.
Knowing what I went through and knowing what I was told, knowing what happened to me medically, and I do say that I'm the premier expert in the country of the extent of damage that this virus can do to the human body. I believe I can talk about that ad nauseum, but I was always amazed, and I mean, this is not ego, but wouldn't somebody want to look at my blood and see like people ask me that all the time in the beginning, like, have they taken your blood? Why aren't they sticking your blood? And is that something in the movies, or is that when people ask me that, it's the only reason I bring it up is that people.
The NIH Recover trial is now biobanking. That's what we call storing blood on 15,000 people. So I mean, they're collecting a lot of blood. I mean, yeah, you're a special guy. I don't know.
Larry, what about
you talked about the brain and the immune system being together, and I don't know if you know my story, but I was very lucid in the coma and went to very deep places, and one of it was I built an incredible relationship in the coma with my immune system. I was talking to it. I was like, kick some ass. I was like, I was like, do your thing. Don't let this thing,
I've done studies on mindfulness, mindful practices, and regulating gene expression. So, maybe you should put it in a can.
Well, I just had hernia surgery and I healed up so quickly. My doctor said, my God, so that was quick. I said, I'm not going to kick ass immune system. I said, these guys, I don't know what they're doing, but I can kick ass.
Well, Lenny, I want to thank you for shedding some light on this new problem and going to be a long-term problem. I think it's been really helpful for us and certainly for our audience. I want to let the audience know that in the early days of my starting my website and podcast, I always called upon Lenny to help me. And Lenny's, besides being a master scientist and a great fellow, he's an enophile, a real wine aficionado. He used to write blogs for me called Wine and the Rheumatologist. Like we need an excuse.
People want it back.
Right. They do. They do. So in your travels, even to Santa Fe, can you make us a wine recommendation as you leave?
Well, when I'm done with this meeting, I definitely will.
Okay.
I had to only drink margaritas last night, so.
Okay.
I'm big on Malbec, Lenny. I'm big on Malbec. I love Malbec.
All right. Lenny, bless you. Thanks so much.
Jack, can I thank Lenny? Lenny, thank you. It's an honor to meet you. And
my privilege, man. I've heard so much about you.
And I heard so much about you and what you do. I keep doing what you do. It's vitally important, and you are a prince among men.
Hey, thanks, man. I'm feeling off right now.
All right, bye.